thanks for the opportunity to be here to tell you about our CACHE colorectal cancer project, which I've been lucky to be a part of the last several months. So colorectal cancer is the second leading cause of cancer death in the US, and unfortunately disproportionately affects people from low socioeconomic status, as well as some racial minorities. We know that death from colorectal cancer is significantly reduced with adequate screening, and that differences in adherence to screening account for a large part of these disparities. Some reasons for this are that screening requires access to a usual source of healthcare, and optimal screening is with a colonoscopy, which usually requires a patient as well as a family member or friend to take time off of work and have access to transportation. And there are likely barriers to other forms of screening as well. So the Collaborative to Advance Clinical Health Equity, or CACHE, in colorectal cancer group was established with the goal to identify disparities in colorectal cancer within the Duke Health System, including access to screening, which is what I'll focus on today. So for this project, we're using data from the Duke electronic health record and have identified patients with a Duke primary care physician who are ages 50 to 75 and otherwise eligible for colon cancer screening. We're looking at appropriate participation in colon cancer screening, which can include a colonoscopy within the last 10 years, a flexible sigmoidoscopy, which is sort of a mini colonoscopy within the last 5 years, stool testing within the last 1 to 3 years, depending on the type, or being indicated by their provider as being up to date in the electronic health record. We have started with a cross-sectional analysis of current adherence data and have plans for a more prospective design as well. So when we looked at adherence to colon cancer screening by sociodemographic factors, we predominantly found differences by socioeconomic status. So this figure here shows adherence to colon cancer screening by insurance type. And you can see that individuals with Medicaid insurance were much less likely to be participating in colon cancer screening compared to those with private insurance or with Medicare. We found a similar trend when looking at community level socioeconomic status. So the Area of Deprivation Index is a composite measure of neighborhood level socioeconomic deprivation that is calculated using census data and then presented by its state decile. And you can see that as the Area of Deprivation Index increased, we found a decreasing proportion of individuals who were adherent to colon cancer screening, with an absolute difference of around 10% between the most disadvantaged and least disadvantaged communities. When we looked at this more closely by screening modality, we found that this was predominantly driven by differences in receipt of a colonoscopy. So in this figure, the blue bar represents proportion of individuals receiving a colonoscopy, while the white bar represents the other screening modalities. And you can see that while the proportion receiving the other screening modalities was fairly similar, there was a large difference in the proportion receiving a colonoscopy. There was a similar trend when looking at the Area of Deprivation Index. And you can see that as the community disadvantage or deprivation increased, the proportion receiving a colonoscopy decreased, while the proportion receiving other screening modalities was overall fairly similar. So from this, we can draw some preliminary conclusions that there are some disparities in participation in colorectal cancer screening within the Duke Health System, as seen nationally. This is predominantly in individuals and communities of lower socioeconomic status, and it's driven largely by differences in colonoscopies. And we need some further investigation into these and other factors in order to design some interventions to mitigate these disparities. There are some challenges and limitations to this work. So first is that the electronic health record data is complex, as has been mentioned. We're fortunate here to have individuals who are very experienced in working with this, but it does present a challenge. There is a lack of data on individuals who are not engaged in regular primary care. So patients who are predominantly seeking care in urgent care or in the emergency room won't be included. And so we'll likely include some of the most disadvantaged individuals and underestimate some disparities. And then we're limited to events that are captured within the Duke Health System. So some may have had screening elsewhere that has not been reported. And then there are nuances to reasons for testing that are not captured. So patients may have had one of these procedures performed for symptoms as opposed to for screening. And it's difficult to tease this out with the data we have. Despite these limitations, though, there's really a wealth of data in the electronic health record, and we're optimistic that we can use it effectively, identify any disparities that exist, and then design some interventions to mitigate these. Thank you.